All right, everyone. We'll go ahead and get started. We're doing a fireside chat on telehealth with Dr. Stephen Hochschuler from the Texas Back Institute, co-founder, and Wendy Whittington, who is the medical director for telehealth at NTT. So, really happy to have these two experts in the field, with us. I guess one of the things that I want to start off with is, telehealth has become a bit of a misnomer. It's covered everything from digital health to video conferencing, and I think there's a lot of mystique around what people talk about when they talk about telehealth. So what I would love to do is just throw it over to Doctors Whittington and Hochschuler to just give us a quick understanding of what they think about when they think about the word telehealth.
It's so confusing. I'll start with my bias a little bit and what it's not. So what it's not is a technology. What it's not is a vendor putting something in place and voila, we have telehealth. It's really a clinical operation. So if you break it down, there's really three simple categories of clinical operation that comprise telehealth. The first category, really the payers and the employers started to try to get patients using ER, expensive care, less. So they set up these telehealth networks where patients could call in and get their problem solved and therefore avoid the emergency room visit. But in that category, we ended up driving up utilization sometimes, and it didn't exactly fit what we expected it would do. The next category is really in acute care in hospitals where we use telehealth to solve specific needs. So you need a specialist to advise on stroke care in the ED. You don't have that specialist on your immediate staff. You beam them in via telehealth. The third category, and I think the one that probably holds more promise, is the management of chronic disease and long-term management of patients within their medical home via video conferencing.
Terrific. Stephen?
Yeah, I've been involved in telehealth one way or another for the last 45 years. I helped Harvard set up WorldCare. The positive is it's successful. The negative is we never figured out a revenue model. So they are now in Dubai, and the Mideast is funding them. But telehealth has a huge potential ROI in terms of global fees, episodes of care, and being an extender of medical care for very cheap investments. So when we started the Harvard project, it cost us $125,000 a workstation. Now every computer is a workstation. The quality might not be as good, but you have on your VDT, you have a camera, and you have access to the world on talking. So anything that's been tried, whether it's hardware, software, vaporware, I've been involved in. And I think, as we just heard from Dr. Whittington, the definition is not clear, nor are the laws. And the laws have to be national. Right now, telehealth can be used internationally. It's open access, but you have to have a situation where you can afford to develop it.
Yeah. I would add to that, Jens, if you want to oversimplify, really telemedicine is the provision of clinical care by a clinician to a patient when you're not right next to each other. That's really all it is. So by that technical definition, and that's the definition that the American Telemedicine Association uses and a lot of others use, by that definition, I was providing telehealth 25 years ago via telephone, giving a patient advice, right? We didn't get paid for it then. The only difference today is we might get paid for it.
Right, well, and that leads me into a pretty interesting, I was doing some research for the panel, and one of the things that I looked at was the fact that out of the $3 trillion that gets spent on healthcare in America, $1 trillion of that is reimbursed through CMS. Of that $1 trillion, $14 million, nearly $14 million, has been spent on telehealth. Why are we in that situation? Why is there not more money spent on telehealth? I mean, it's obviously something that we have the technology to address. And then secondary to that, maybe to Wendy, is what is the role of the consumer in that, and how is telehealth going to get paid for?
I think with any disruptive technology, there's a lot of hesitation. So whether it was the internet in the 2000s went down, and now it's back and it runs everything. Whether it was Amazon, whether it was Netflix, and you compare it to Blockbuster, everybody was betting on Blockbuster. They were wrong. Disruptive technology. Telehealth is a disruptive technology. But as in the book Inside the Tornado out of MIT, which many of you probably have read, you have innovators, then you have a dead phase, then you have the early adopters, and then you get to stability or really boredom, because no decisions will be made, because the safest thing to do is not make a decision. I believe telehealth is starting to break through, and I've worked with pretty much every company out there. And I think some are in hardware, some are in software, some are international, some are national. It's coming.
And Wendy, what about the role of the consumer?
Sure, I'm just going to pick up on that last point for a minute, and then I'll roll into the consumerism. When you think about it, the incentives just aren't aligned, right? So it's the right thing for patients, absolutely. You know, when is it ever the right thing to post-op, for example, if you have a little question and you want one little thing to be checked, when is it ever the right thing to get in the car and drive however many miles to see a doctor and sit in a waiting room? It's just not the right thing, right? So if we just looked at a patient-centered world and doing the right thing, telehealth wins all the time. But the incentives are not aligned. It's all about the regulations and the payment. And if I'm a healthcare delivery organization and I'm going to get reimbursed every time that patient walks through my door, or every time I do something else with that patient, why am I going to invest in a technology that, even though it's better for the patient, if it's going to help sink me before we sort out this whole payment mess in this country? So that's just my...
I would add two things to what Dr. Whittington said. Number one, it saves the patient money. So if post-operatively, I'm a spine surgeon, post-operatively I want a wound check, you don't have to drive 300 miles, and we're in Texas, so 300 miles is nothing. The second thing is that if you're going to do episodes of care or global fees, you can cut back the cost on everything, pre-surgery, post-surgery, rehabilitation, all of it, because you don't need nearly as many visits. We did a study 20 years ago with Telehealth where we needed 3 ISDN lines. That's the way it was. You had to upload digital information, you had to download, and we did a study between one of our offices in Midland, which is 500 miles away from Plano, and I hired a PhD student from SMU to analyze whether people liked it or not. And guess what? Real insult. They like seeing me telemedically much better. So we then asked why. And the reason was they had my undivided attention. I could show them the MRI and point to different things. The only negative was, unlike TV, where you can look eyeball to eyeball, since the camera was here, you weren't looking directly in the eyeballs of the patient. But we learned a lot. But it didn't take off for all the reason Dr. Whittington said, that where's the money going? Now everybody's, and you heard in the last Dr. Desai, everybody's looking at cost control, cost cutting. And we own parts of several hospitals in Texas, which is cost plus. Well, guess what? I also have part ownership in a hospital in Arizona, which is carve out. Cost plus makes no sense, but I'll take my check every month. But it makes no sense. So if an implant, a hip, costs $1,500 in Texas, you can charge like 1.5 times what it cost you. In Arizona, you only get so much money for the implant, the procedure, and everything else. Much more sense. But politics run it.
Yeah, we didn't pick up the consumerism piece, so
Please.
just finishing that up. Consumers are demanding it, right? We all want it. Certainly the generation after us, our young adult children, want these kind of conveniences. They want what they want immediately. I think the challenge is to make it all work within a clinical operation that makes sense and to keep the patient at the center of care.
Absolutely. Well, we've talked a lot about the clinical side of this between the three of us. It's kind of interesting. Another thing that we've looked at, two of the major pieces of legislation in the telehealth space, both the Chronic Care Act and the Connect for Health Act, were sponsored by two Republican senators from Mississippi, who are probably the two biggest proponents in Congress of telehealth. You guys are both from Texas. I'm from California, ostensibly debating to be the center of the world. What's going on in Mississippi?
Well, I'm not sure. It just is. I can tell you what's occurred in Texas is the TMA, and I used to serve on a board there, they're protecting doctors, and I have nothing against protecting doctors. But the biggest obstacle was a woman in the TMA who was against it. And if you remember, the company that went public, I mentioned it earlier, Teladoc. Teladoc went public, $15 a share. That afternoon it closed at 30. That's in Texas, about 20 miles from our main office. It was brilliant, but they couldn't use it in Texas. The woman who was against it quit the TMA, Texas Medical Association, and guess what she did? Started her own telehealth company. So when you look at politics and you just follow the dollar, you'll see what the motivators are.
Yeah, so I think to further answer your question, Jens, what's happening there is a good thing, right? It's folks recognizing a need for their constituents and pushing it in the right direction. But I would caution you, if you look at the map of the US and you look at all the different regulations and all the different laws that have been put into place around telehealth, you can be falsely led to believe that, the environment is better in this state versus this state. I will tell you, it is a confusing web everywhere, and part of putting in a good telehealth program is having somebody who really understands how to navigate that web, because just because there's regulations doesn't mean it's done.
Absolutely, absolutely. Do you think that there are any? I know that some of the things that drove telehealth in Mississippi was a chronically ill, larger chronically ill population, and the ability to the fact that they could not attract doctors. All the doctors were fleeing to the coast. Is that any sort of indicator of how telehealth will evolve nationally?
I think yes.
No, I agree with that. I think the answer is yes. I think that as people get more educated and we become more cost conscious, and as investors, as we look at ROI, the dollars that could be generated, I mentioned earlier, when we open a new office, we have about 12 offices in Texas. When we open a new office, what we have to do is we have to either buy, lease, or sublet brick and mortar. So I compare it to Netflix. Now, if I were to bring in the best physical therapists in Texas and the best chiropractors who are always afraid we're going to steal their patient, we have no interest in that. All of a sudden, they can consult with us telemedically, and it'll do a better physical exam than any of my partners will do, especially the physical therapists, and let them beam in. So now they can be a primary kind of advisor, tell us the history and physical. We could tell them whether they need an MRI, don't, whether they need medicine, and all scripts you can use. There are a lot of ways of doing this now. And guess what? I've now opened another 200 offices in Texas with no leases, no real estate, no blockbuster. We're doing it direct through telemedicine. And nobody's taken that. I've mentioned this in a lot of different formats. You've got to get approval from the state the medical boards. Makes ultimate sense. Use providers who can add to what you do.
It does make total sense. It does, but when you go back to that it's now 3.6 trillion, right, spend, the way we're delivering care in this country is not working, right? Of that 3.6, we're throwing a third of it down the drain. We know it's wasted. So if we can just get our act together and stop worrying about, who profits most and all the elbow games, I think it's the right thing. It makes total sense.
The other thing that's going on, Sig, is that you that I see in the audience? I didn't see you earlier. There's a thought leader. Anyway, lost my train of thought.
Well, let me throw an open question out there. This should be kind of a fun one. So the internet is ubiquitous globally, and so that will obviously produce incredible changes with respect to getting video from one side of the world to the other. Are there any megatrends that you want to call out with respect to telehealth, and where do you see this going as it grows?
I see it going in a lot of directions. I'm interested in the software side, not the hardware. You can buy that from other vendors. There are a lot of companies out there that are pretty good, like Video, an Israeli company that few people have heard of, but it's a great company. There are all sorts of opportunities. We started doing a couple of projects in China 11 years ago. The Chinese thirst for knowledge, and they want second opinions. And you could do store and forward, or you can do real time. It doesn't matter. The technology is there to do this. And the name of the game, for instance, you look at CVS. CVS is buying, I forgot which insurance company. Aetna. How in the hell can they get away with doing that? Well, it's going to happen in telehealth as well. So you've got to be thinking downstream. I've always been downstream, but 40 years too soon, and working with Harvard. But now it's time.
I think that the mega trend is that this technology, there's nothing special about it, right? This is not sexy technology. The mega trend is that this technology will soon be commoditized. So much like a physician today, part of her regular routine is picking up the telephone and calling a patient. Part of our regular routine is just going to be that video conferencing. It's not going to be a technology-driven movement.
That's terrific. Well, thank you. I think we'll. I'd love to open it up and take a couple of questions. Can we do that, Mark? Real. Do we have a mic out there? Take this gentleman in the blue shirt. You. Yes, sir. Sorry.
Yeah, a quick question about the future of telemedicine. Combined with the merging of what's going on in healthcare data, the digitization of data is, I believe, enabling some major changes in telemedicine. There's one company that I'm aware of called Hypnosis in Minneapolis that uses artificial intelligence, rule-based AI, basically, to do diagnoses, kind of like with patients who simply answer questions. It's a sort of a digital version of prompt care. I mean, they don't necessarily have the background on the patient, but they nonetheless are able to map onto, I think, 80 or so ICD codes with 100% differential diagnosis. It's a triage value, however, that I think is even greater in what they do. In other words, a given patient might say, after they answered the question, the software might conclude, not really sure what you've got, but you ought to come in and see a cardiologist today. That kind of thing.
I'm sorry, go ahead.
Tools like that, I think, that use AI and other forms of clinical decision support are absolutely where it has to go. The way I think of those things in the context of telemedicine is no different than the way I think of it in the context of face-to-face care. I think telemedicine is just another way to reach our patient, and we're definitely going to have to use tools like those underneath it all.
Let's do one more, Martin.
One quick comment. We did a company 25 years ago, which was a artificial intelligence binary algorithm with experts. And we could have saved GM because we pitched them, and we're going to charge them nothing, but take their historical 5-year records and then split 50-50 savings on a go forward. And 70% of their injuries when they built a car were spine related. They had no interest because of vested groups. So you got to always figure out who's going to try to block you. And that's the problem with AI. There are people who did this for an emergency room 30 years ago, blocked. So these are things you've got to be willing to fight and have long-term hesitancy in terms of not giving up.
Okay, last question before we catch these guys on the wine train.
I'm curious what role you see consumer-facing medical devices playing in the telehealth, augmenting the telehealth experience.
Huge, right? Huge. And it's easy. We can do it now, right? There are Bluetooth plugins for all sorts of telehealth scenarios. So I think it's a huge role that shouldn't be underestimated, but I think we still have a lot of work to do to build the foundation to get those operations under control before we jump to it. I wouldn't make the mistake that just because we have those devices that we're there.
I would add one thing to that I've helped put together a company called FreeLink Technologies. And from the question you asked, there are three ways of transmitting digital information. There's Bluetooth, there's RF, and then there's FMR, near field magnetic resonance. The trouble with Bluetooth and with RF, and right now J&J is fighting that battle, as are others. Pacemakers, if you remember that show, Homeland, where the vice president was knocked off by somebody interfering with his pacemaker, guess what? You can interfere with Bluetooth, you can interfere with RF. The reason you can't with NFMR, it's only 10 to 11 inches, the field you have to get into. So if I move, you're at the wrong place. So it's a tremendous opportunity. It can be used in audio for signaling of sound. Right now we're working with the Department of Defense for the wireless soldier. It's fascinating. So keep your eye peeled. What's next?
So as investors, double down on NFR. Any other recommendations? And then we'll let you go.
I don't know any startups today in telemedicine, but I've been involved with several, and none of them have really made it, but the time's now.
There's a ton of them. I would just caution that it's going to be commoditized, right? So look for the differentiators. Most of the telehealth companies out there are doing a lot of the same.
Yeah.
Brian.
Same question, Stephen, and to both of you. You're looking at the U.S. market, and we have lots of barriers and things. How do you see this in the international market, and how has that changed, right? What's that opportunity?
Everything's going international, as you know, with the internet. We are right now in China, working there, South Africa. We've been asked to come into Turkey. I won't touch Turkey right now. But the truth is, the whole world is consolidated based on the internet. So as somebody mentioned that things are accelerating, change is occurring fast now, watch.
All right, Mark's going to start playing us off if we're not careful. So thank you.